I want to thank you all for allowing me to be here and present on our new intervention program. This behavioral change intervention will focus on patients with comorbid type 2 diabetes and depression. A strong correlation has been established between depression and complications of diabetes. Patients diagnosed with diabetes are twice as likely to experience depression during their lifetime as patients without diabetes. These patients also have higher medical costs and worse health outcomes than patients diagnosed with diabetes alone. The target population for this intervention are patients, both men and women, who are between the ages of 18 and 75 years old and receiving care here in the IHCC. The patients will have a current diagnosis of both depression and diabetes. Based on this criteria, there are currently about 200 active patients who can be included in this intervention. Treatment provided for patients with comorbid type 2 diabetes and depression by treating the conditions together is much more effective. Physical activity and lifestyle interventions are beneficial for improving health in patients with comorbid depression and diabetes, as has been shown by Program Active in the past. This type of treatment approach is realistic to implement and can be effective in treatment of comorbid depression and diabetes. By treating both these conditions together, patients will have better outcomes while at the same time lowering the total cost of care. Risk stratification will be used to determine the proper intervention approach for each patient in the intervention. Patients will be placed in the level of intervention that corresponds to the highest level of risk for either diagnosis. A patient who is at level 1 for diabetes but level 2 for depression will be placed at the level 2 overall. Low risk or level 1 is determined by mild depression, which is a PHQ-9 score of between 5 and 9, and pre-diabetes based upon an A1C score between 5.7 and 6.4%. So moderate risk or level 2 is determined by moderate depression, which is a PHQ-9 score between 10 and 14, and diabetes based upon an A1C between 6.5 and 9. Severe risk, or level 3, is determined by moderately severe to severe depression, which is a PHQ-9 score greater than or equal to 15, and uncontrolled diabetes based on an A1C greater than 9%. Patients participating in the intervention will receive care based upon their individual determined level of risk. Patients will stay at the current level of risk, not move into a lower level of care for a minimum of 12 months, even if the patient improves and the risk level for the patient is lowered. This will prevent patients from losing the improvements that they've made in the intervention through backsliding. This intervention program will utilize the National Diabetes Prevention Program for education materials, approaches, and website support. Low-risk patients will receive interventions focused on education and preventative health for prediabetes and mild depression. Education materials and websites will be used extensively. Moderate-risk patients will receive the same preventative care information and education materials as low-risk patients. Moderate-risk patients will also meet with a behavioral health consultant for behavior modification using CBT, or have group counseling made available if the patient is receptive. Severe risk patients will receive a higher level of personal intervention. Patients at this risk level will also receive ongoing education and meeting with the BHC for behavioral modification. Group counseling and individual counseling will both be used for severe risk patients. These patients will also receive certified diabetic education referrals, have an RN case manager assigned to them, and receive an assessment from a psychiatrist around their depression. Goals assigned for each of the risk levels in this intervention will measure the effectiveness of the interventions. For low-risk patients, the goal is that 50% of patients in level 1 will make lifestyle changes that will lead to a weight loss of 5 to 7% after 3 months in the program, and will lower their A1C at least 0.5%. Moderate risk patient goals are that 25% of patients in level 1 intervention will lower their A1C at least 1 percentage point and improve their PHQ-9 scores by at least 5 points after 3 months in the program. Severe risk goals are that 25% of patients in the level 3 intervention will lower their A1C at least 1 percentage point and improve their PHQ-9 scores by enough to move down at least 1 risk level after 3 months in the program. Anticipated clinical outcomes for the interventions are that PHQ-9 scores will decrease in 60% of the patients completing the program. It's also anticipated that A1C levels will decrease in 75% of the patients, and 50% will decrease enough to move down at least 1 risk stratification level in patients completing the overall intervention. It's predicted that there will be a reduction in PCP visits, ER utilization, and hospitalization from this intervention. Currently, we plan on starting the program on Monday. So does anyone have any questions